Hello, I'm Bruce Gewirtz, Vice Dean for Academic Affairs and Surgeon-in-Chief here at Cedars Sinai. And this afternoon it's my great pleasure to welcome Joanna Chikwe, the Schaefer Family Professor and Chair of Cardiac Surgery here, which is a new department which has done just exceptionally well under Joanna's leadership. I wonder, Joanna, if you could tell us a little bit about your background, where you were born, and how you ended up in this business.
Well, as you can probably tell from my accent, I was born in England, in Birmingham, which is notable for being England's second city. It's almost as glamorous as Birmingham, Alabama. And I left when I was about 16, and I've not actually been back. I went to medical school after about 2 years studying art in Italy. I really loved art. Originally, I'd planned to go and do mission work in Africa, but my parents sort of suggested that it might be much nicer and safer to study fine art in Florence. So I did that for 2 years, which was amazing, and then settled down and studied medicine.
Well, that's quite an unusual pattern for a cardiac surgeon. In medical school, did you first get the idea that cardiac surgery might be the future for you?
I knew I wanted to be a cardiac surgeon when I was about 6, and people sort of often ask me why. And I have no idea. I mean, who knows why a 6-year-old wants to do what a 6-year-old wants to do? I think my parents, neither of whom went to university, in fact, nobody in my family went to university, were immensely impressed by a surgeon called Magdi Yacoub, who many people listening will know. He was just this phenomenal Egyptian cardiac surgeon that operated mostly on children and flew around the world doing, again, phenomenal work. And I wonder if that's what inspired me, but it's really something I haven't ever deviated from.
Yeah, it's quite interesting. So after medical school, I know in England, the pattern of training is a little bit different than the United States. Where did you begin your surgical training?
So it's very different in England. We specialise much earlier at school. At the age of 15 or 16, you're picking 3 subjects, and those are subjects that will take you through to university. So that was challenging for me because the subjects that I needed to do medicine, which was biology, physics, chemistry, weren't my passions. I didn't love chemistry, that's for sure. I loved art, I loved literature. So I was lucky enough to spend time in Italy getting that passion out of my system. And then I went to medical school in London, followed by Oxford. And Oxford is a wonderful place, and it was a very liberal education in medicine as well as a very rigorous one. It gave me just a remarkable foundation in terms of academic approach to not just patient care, but also thinking more carefully about the subject. And then I did my general surgery and cardiac surgery training in Cambridge and London before I came to New York. And my goal in coming to New York was to really get much more time operating at a really high level, with a plan to only stay 1 year. But 13 years on, I came to California, never really looked back.
So that's a fantastic story, and it was our obviously great good fortune that we got you first to the United States and then made it clear that California was the place to be. What differences did you see in medicine in general, and then secondly in cardiac surgery, between the continent and the United States?
So that's a fascinating question, and there were differences that really troubled me for a long time. The wonderful thing about the National Health Service is that it offers care to everyone irrespective of their ability to pay. So you could be diagnosed with something that would require the most advanced and complex surgery, expect to have that, expect to have it at the highest level, and go home and never receive a bill. And I genuinely was brought up in a culture that believed healthcare was a right, not that it was a discretionary thing that you should be able to obtain based on your ability to pay for it. And that meant that the quality of healthcare for the broad population was really quite excellent, and a lot of it was driven by this exceptional primary care part of the profession. I was quite dismissive at medical school of primary care because I knew I wanted to be a cardiac surgeon, and that's where all the excitement and the glamour is. But they make you spend time with primary care docs when you're learning medicine, and to really appreciate the intellectual approach, their ability to triage patients effectively, not waste the patient's time and not waste the time and effort of specialists, was phenomenal. And because people aren't motivated by increasing their salary by the number of procedures that they do, the care was absolutely appropriate. It was really geared around what's best for the patient at every step of the way. And the one limiting factor is because the government is paying for it, there are relative caps on expenditure that impact what you can do at the highest level. So if you flip the coin and compare that with America, the exciting thing about coming to America was that the care at its best was better. When cost is much less of a driver and it's really about excellence, and there's a sort of free market component so that you've got not just individuals but institutions competing to be the best, that drives an exceptionalism that was, I feel now, lacking in the UK.
That's very interesting, and it'll be also very interesting to see in the years in the future how the American system deals with the compelling need to control costs, which we've talked about for the 50 years that I've been in medicine and haven't made tremendous progress on. So let's talk a little bit about your practice of cardiac surgery. For those in the audience, one very simplistic way to look at the heart is a mechanical organ, sort of like a carburetor that regulates the flow of air and gasoline, in this case blood, in one direction or the other. And I know that one of your passions is what is generally called structural heart disease. I wonder if you could comment a little bit about structural heart disease, how your view of that was so captivating, and then perhaps we can talk about some of the new treatments that I know you've been part of driving both nationally and across the world.
So I'm going to go back to your view of the heart as a carburetor, and people that describe heart surgery like flying an aeroplane, we should be able to learn from that complex type of situation, are missing a trick, because it absolutely isn't mechanical. The heart is more like a high-level racehorse. It's capricious, it's beautiful, it's not designed to do many of the things that we ask of it when we're trying to treat illness. So almost every operation is a little bit of an adventure, and it's the job of the team to try and take the adventure out of each operation. And structural heart disease is essentially what happens when one or more of the 4 valves in the heart doesn't work. So your heart's divided into 4 chambers, and valves are designed to make sure that the blood just keeps flowing forwards in the right direction. And what happens in structural heart disease or valvular heart disease is those valves can either be too tight or too loose. They leak. And my favorite valve is the mitral valve. It's just this beautiful, complex, individual valve. Every valve is different, and every time it goes wrong in a slightly different way. And when that leaks, it's initially you can tolerate it. Your heart's working twice as hard to do the job it's designed to do, to get the right amount of blood to move forward, because half the blood is moving backwards with every heartbeat. And it's a joy to try and repair it, for many, many reasons, not least of which is because it just has this huge impact on people. When your heart valves go wrong, it's something you feel. There's a huge number of people with slight problems. They don't realize they've got them. But the people that I see genuinely are unable to do the day-to-day things that they enjoy. Plus, this valve problem is going to put a cap on their ability to live months or years. So fixing that is just incredibly rewarding.
So the history of valve replacement is a very interesting one, and maybe you could give us your view of how it has evolved since Bailey and others started doing the first procedures on the mitral valve.
Well, it's an interesting one because it displays surgeons at their best and their worst. You had to be quite immune to human kindness, nature and rules, at the beginning of heart surgery to do operations in people that were likely not going to work, were really pushing the boundaries of what was possible. And there are some genuinely hair-raising stories about how the first successful mitral repairs were conducted by a surgeon, now notable for what he achieved, running around Philadelphia scheduling 2 or 3 patients on the same day, so that when the first patient died on the table, and this is decades and decades ago, he was able to hop across town to the next patient before he got removed from the credentials list at that hospital and operate on the second patient who survived the surgery. And the early pioneers really had to push the boundaries in quite a way that I think today we might not find acceptable. And one of the big drivers of advances in heart surgery was actually the Second World War, where understanding how to deal with a heart that had been prone to trauma drove a lot of the advances that we rely on today. The breakthrough was the heart-lung machine. So a mitral valve is a little bit like a parachute. You've got all of this wonderful soft material that's held in place by these sort of delicate strings. And I think of fixing a mitral valve a bit like fixing a parachute as you were flying through the air. And what the heart-lung bypass machine does is allows you just to freeze frame for an instant. You can stop the heart safely, you can open it up safely, you can operate in a beautiful still field. So the invention of the heart-lung machine was transformative, and surgery's just really expanded quite remarkably since then. And the question is whether the whole new technological developments that allow similar cures to be delivered through wires, so without surgery, that's probably the most pressing question in my specialty right now.
Now, I understand that robotic repair of the mitral valves is, in many cases, replacing open sternotomy and other repairs. I wonder if you could tell us a little bit about how you got interested in that and how you see that as an advance over more traditional direct open surgical approaches.
Yeah, so if you sort of put your hand on the front of your chest as you listen to this, there's this sort of bone right under the palm of your hand, and that's the breastbone or the sternum. And in order to get at the heart, we literally take a builder's saw and sort of saw through that while you're asleep, and that's the traditional way to get to the heart and the valves and the coronary arteries. And anything that you can do to avoid doing that is much, much more appealing to the average patient, even though it turns an operation into trying to fix your car without taking up the lid of the bonnet, or whatever you call it in American, and fix it under the lid. The robot is this wonderful, complex piece of equipment that allows you to place tiny, delicate little instruments in through much smaller holes, not much bigger than a little finger, between the ribs without going through the sternum. And if you can combine that complex piece of equipment and deliver a safe operation, and that operation is already pretty complex, it's transformative for patients. And robotic mitral surgery is something that I wanted to do almost as soon as I learned how to do mitral valve repair a decade ago. And there are so few people that do it well. It's taken a few years to find the right team, the right platform to do it. And Cedars is really quite remarkable in that it's able to do really exceptional surgery using the robots at pretty much every level in cardiac. There are not many centers that do it at quite this level.
Yeah, one of the things that so impresses me about robotic surgery, particularly cardiac, is the visualization, how detailed the look is, and how three-dimensional now the field is in robotic surgery. And I'm just loving to hope that in my field of vascular surgery, that we'll be able to find an excuse to use the robot so we can enjoy the fun of doing it.
It is astonishing, and for surgeons that haven't sat down on a robot and seen this amazing three-dimensional, hugely magnified view of what they're operating on inside the heart, it's really difficult to help them understand quite how transformative it is. And it's just a joy once you've got over the hurdle of that additional level of complexity to do what can be a simple operation. It's just wonderful.
And to your point, I mean, without the sternotomy of the breastbone and the subsequent repair, the patients seem to get over the procedure so much more easy and return to their normal activities. About how long does it take for a patient to recover from the open surgery versus the robotic surgery?
It's often a lot shorter with the robotic surgery, and I would say 3 or 4 days in the hospital. I think with some patients you could get it down to even less. One thing I'm always cautious about with heart surgery is that we're not just focused on the how soon can I get out of hospital. The whole rationale for subjecting yourself to an operation at this level is to make sure that you have the best possible outcome for the rest of your life, that we're going to keep you out of hospital, that you're going to get back to doing all of the things that you want to do. And I find that with the robot, people are usually up and about, playing their 18 holes of golf or whatever, much, much faster than they are with a sternotomy. And the key thing is not to compromise the quality of what you've done, so that that's their story for many decades, not just a few years.
No, it's very, very, very interesting. And now one of the other things that I know we've all focused on here at Cedars Sinai is that historically the surgical professions have not been gender balanced. That is, if you look back, neurosurgery, orthopedics, and cardiac surgery were bastions of males and few females. And how has cardiac surgery progressed over the last decade in that area?
It's progressed remarkably little. I think back when Nina Brownwald, who's one of the first female cardiac surgeons, took her boards, there were 3 other women taking the boards at that time out of maybe 80, 100 candidates. Maybe last month there were a few more, but right now I think 3% of cardiac surgeons are women in the US.
Do you think the cultural barriers to women training in cardiac surgery are being removed intelligently, or how would you characterize that?
That's a great and a pretty difficult question to answer. I suspect that one of the biggest barriers is the lack of role models, and that is self-perpetuating. There are a few things that I think are incredibly important to try and shift that, and you might be sitting there thinking, well, why shift it? And the compelling reason, if you're a patient, is that you want your surgeon to be the best of the largest possible pool of candidates. And if you're only drawing a pool of candidates from 50% of the population, you may not be getting the absolute best. So that's the compelling rationale to try and address this, one. And two, there is increasing amounts of evidence that if you're treated by someone that reflects your concerns, your perspectives, understands you, be that on the basis of socioeconomic background, ethnic background, gender, that really enhances your care. So there are many, many reasons why it's important to address this. And I think going back to the why and the how, role models are important. I'm planning the annual meeting of the largest academic association in cardiac surgery. I see it as my job to ensure that there is a really highly qualified woman on the podium, and the podium is maybe 10, 15 people each time for every single session, because if we don't have role models, it's very difficult to move the needle.
Well, absolutely. And we at Cedars Sinai certainly see you as a extremely important role model in our procedural specialties overall, not just cardiac surgery. If I were to ask you what are the most likely and most exciting 2 or 3 developments in cardiac surgery that you would predict over the next 5 years, what would they be?
Gosh. So cardiac surgery is a mature specialty and a mature technology, by which I mean we're not at the point where dramatic developments are happening and the fun pioneering is ongoing. We're at a point where disruptive technology is really what's driving the biggest conversations. So disruptive technology is essentially what cardiologists predominantly have developed to allow similar operations to be done without making any incisions, just making punctures in veins. So for example, in my field, one of the biggest advances is development of a clip that if you were falling through the air with your parachute, and your parachute is the mitral valve, instead of me using cardiac surgery and a heart-lung machine to freeze frame that moment and then meticulously sew the tear and the parachute together to get it to work, the cardiologist is going free falling with you, just sort of stapling the clip, the parachute back together. And it's a really controversial question right now for patients that are suitable for surgery. Are they better off with a clip delivered through a vein in the leg? And it's been a real joy to be part of leading a NIH-sponsored pivotal trial to address that question by randomizing patients to one or the other. Because randomizing people is what you really need to do to answer that question, which one is better. But if you were a patient, think how little you'd want to be randomized. So to something as radically different as surgery versus a little clip. So these are the sort of really, I think, most challenging questions, but they're also the most exciting questions for our specialty.
Well, terrific. It's funny of the missed metaphor of a carburetor. The first time I heard that, John Templeton, who was the chief of cardiac surgery in Philadelphia at Jefferson, someone asked him, isn't fixing a valve like fixing a carburetor? And he said, yeah, it is if the car is going 100 miles an hour and you're fixing it while it's running. So I certainly get your point of view. Well, it's delightful to have a chance to chat with you. We're very proud of what you've done and the people that you've recruited to make the cardiac surgery department truly one of the best in the country and one of the best in the world. So thank you for joining us today.
Thank you very much. It's been a pleasure.